Here we will talk a little basics about lung ultrasound. The ribs, the skin and soft tissue, the intercostal muscles and pleura are easily identifiable. We can also appreciate the movement of the pleura. Beyond this, the lung is full of air and there is scatter of ultrasound waves everywhere. We can appreciate some artifacts in normal lungs. When the air is replaced by fluid or consolidation of mass, the ultrasound waves get transmitted, producing images different from what is seen with normal lung. And based on these images, we ascribe some pathological diagnosis. Now, utilities for pneumothorax, pleural effusion, either simple, whether it's free floating fluid, or complicated with debris, loculations, septations, fibrous bands. Pulmonary edema, we should be able to distinguish also between cardiogenic and non-cardiogenic pulmonary edema. And consolidation and collapse in atelectasis. The structures we need to identify are the A lines, the B lines, the pleural movement both on the B and M mode, and appreciation of the lung pulse, air bronchogram both static and dynamic, the shred sign, and hypoechoic pleural effusions, debris bands and associated consolidation. So these are the basics. If we can identify, we will be able to ascribe a diagnosis. The probe which is best suited for chest examination is a curvilinear probe. When held across the ribs, we see the classic bat sign with the ribs and pleura in relation to each other. We can also place it in between ribs for more detailing. The linear probe gives better detail of the pleura because it is more superficial. The phased array probe is not suitable. Now what about these A lines? These are reverberation artifacts of the pleura. So pleura is a shiny, shimmery structure, and if you see here, as I play the video, you can see a lot of shiny, equally spaced lines emanating from the pleura. These are called A lines, and these are seen in normal lung, and these are also seen in pneumothorax. So the presence of A lines means there is air beyond the pleura, normal or abnormal. What about the B lines? The B lines, they start right from the pleura, and they are produced when the air is replaced by something, fluid or consolidation. And the B lines are described as like rockets which fire from the pleura right to the end of the screen. And you can also appreciate them like torchlights will move across the entire pleura. If there are more than 2 lines in one field, then we call it significant, and it generally implies the presence of either fluid or a consolidation. You can see in this video very diffuse pulmonary edema. When it is very diffuse, the pleura is still very shiny, it's likely to be cardiogenic. And in non-cardiogenic, the pleura would appear a little jagged. There could be more appreciation of the shred sign. And those are likely to be non-cardiogenic pulmonary edema. I'll just show you in this video how does the diffuse B lines look like. So you can see the entire lung looks very bright, almost diffusely white. This is a patient who had cardiogenic pulmonary edema. So lots of lines which have actually become confluent. What about pleural effusion? This is a video playing a pleural effusion. You can see the hypoechoic fluid above the diaphragm. You see as I go up, you can see more fluid and that collapsed lung in below. And as we come down, you can see here still up, a lot of collection, hypoechoic fluid. And then as we come down, we can also appreciate some amount of fluid below the diaphragm as well. You see, I've just made a still image and you can see fluid below the diaphragm, also just above the spleen. So this is a patient who has both pleural effusion and ascites. There is fluid both below and above the diaphragm. So whenever we look for pleural effusion, we should ascertain whether the fluid is above or below the diaphragm. Here it was on both sides of it. We give you another image of a pleural effusion. Here you can see the kidneys. There's no fluid between the kidney and the liver. There is a rib shadow which comes as a black shadow in between, and as we go up, you can see the diaphragm, and then you can see above the diaphragm the collapsed lung. The bright shadows inside tell you that the collapsed lung contains air. And as we see here, there is no fluid below the diaphragm. It's all above the diaphragm. As we go up, you can appreciate the pleural effusion. So this is a patient who only has a pleural effusion. And if we could call it, it will be considered a simple pleural effusion. This patient has a congestive heart failure with an effusion. And then we come to the pleural movement. You see this very shiny structure, pleura. You can see the ribs on the either side. This is also called the bat sign, showing the relationship of the ribs to the pleura. And as I play the video, you can see the shimmering of the pleura. This shimmering tells you that the visceral and the parietal pleura are gliding against each other. And the presence of this tells you that there is no pneumothorax. This loss of shimmering could be an indicator of the presence of pneumothorax, but sometimes when the tidal volumes are very low or there is a dense consolidation, the movement of the pleura may not be very appreciable. But then in such consolidated and fluid-filled lung, there is transmission of the cardiac pulses to the pleura, which is known as a lung pulse, and that pulsation rate will be equivalent to the heart rate. So if a lung pulse is appreciated, it means there is no pneumothorax. If the shimmering of the line is appreciated, there is no pneumothorax. And also if a B line is appreciated, there is no pneumothorax, because B line has to start right from the pleura, and it can only be transmitted if there is no air in between. You can appreciate again the shimmering of the pleura. So this is a normal lung. And when we put it in the M mode, we pass the beam through the pleura. You can see the upper half is looks like a barcode or a stratosphere sign, they call it. You can see the shiny pleura, and then below that you can see a sand-like appearance called the seashore appearance, and this is seen in a normal aerated lung. If there is pneumothorax, the whole thing would look like a stratosphere. There will be no this sea sand-like appearance. And then this is what a consolidation looks like. In consolidation, what happens is, because the lungs have become solid, they transmit the ultrasound waves. And because the air is inside this consolidated area, it will show as very shiny, bright structures. And in the presence of an air bronchogram, the air moves in and out of that consolidation, which would appear like a starry sign. So the twinkling may be there, the bright spots will come and go and come and go. This is more likely to happen in consolidation. That's called an air bronchogram sign. Or if it is persistently shiny, then it's more likely to be a collapse. So here we see the kidney and the spleen. And as we move up, you can appreciate here that there is transmission of the ultrasound wave. In between these black areas are the rib shadows throughout. And you can also appreciate like a starry night appearance where the air is getting inside and coming out. This is a consolidation. Sometimes the consolidation may be associated with a pleural effusion, or it could be just a consolidation. So this is what we had to talk about for the basics of the ultrasound which is required in intensive care.